And in the next 10 minutes, we will master the usage of cholinergic drugs and their mechanism of action.
Master.
The first use of cholinergic drugs is as myotics, as in glaucoma. So first we should know what is glaucoma. This much we already know that glaucoma is something in which the intraocular pressure rises. Let's have a look at the anatomy of eye. Let's say this is our lens. These are our suspensory ligaments. This is ciliary body. This one is iris. And do you know what is the space in the iris called?
Pupil.
Pupil. So this will be pupil. And anterior most we will have this cornea. So let's assume this is our cornea. So this is the normal anatomy of eye. What happens? We have blood vessels in the ciliary body. These blood vessels form aqueous humor. We know what is aqueous humor. So aqueous humor is being formed. It is being released anteriorly from this pupil, and at the angle between this cornea and iris. Can you appreciate this angle?
Very much.
There is an angle formation between cornea and iris. Here we have a canal called canal of Schlemm. Aqueous humor passes from this canal of Schlemm and it is drained. Intraocular pressure is maintained. Glaucoma occurs by two reasons. Either this drainage is hampered or there is excessive production of aqueous humor. So, by knowing this, now we can see glaucoma can be of two types. I mentioned that angle. So, if that angle is open, we call it open angle glaucoma. Means the angle is open, drainage is good, but there is so much production of aqueous humor. So, there will be rise in intraocular pressure. We will call it open angle glaucoma. In another condition, second type of glaucoma, angle closure glaucoma, that iridocorneal angle is narrowed or blocked. That causes poor drainage of aqueous humor, so it will also lead to glaucoma. In this picture, you can see a person with glaucoma sees this blackishness, and this is progressive and irreversible. Finally, the patient will end up into complete blindness. First, we will discuss open angle glaucoma. In open angle glaucoma, cholinergic drugs like pilocarpine and physostigmine are given. What these drugs do, they are myotics. As I mentioned, they are myotics. They will increase the tone of the ciliary muscles, due to which the drainage of the aqueous humor from the canal of Schlemm is improved. And this drainage of the aqueous humor from the canal of Schlemm has given a fancy name, which is called trabecular meshwork outflow. So finally, these two drugs will improve the trabecular meshwork outflow. Other drugs which can be used in open angle glaucoma are latanoprost, ocular beta blockers, brimonidine, dorzolamide, and dipivefrin. Second kind of glaucoma, the angle closure glaucoma, in which we also give myotics. But the action, the mechanism of action is slightly different. These myotics contract the sphincter pupillae muscle, due to which the angle between the iris and cornea, it is freed. You see, this is the iris. We have cornea. Here the angle is being formed. So, if this angle, because we are studying angle closure glaucoma, if anyhow we are able to open this angle, widen this angle closure glaucoma will be relieved. So, these drugs contract the sphincter pupillae muscle, due to which iridocorneal angle, the contact between iris and cornea is reduced and the angle is widened. This is second type of glaucoma, and in both type of glaucoma we are given myotics. So this was the first use of cholinergic drugs. Another use, we use it in the reversal of mydriatic drug. Mydriatics are the drug which cause dilatation of the pupil. They are generally administered when we have to do fundoscopy, examination of retina, or when we have to do refraction testing, we get our eyes checked. After the procedure, our eyes are mydriatic, but it leads to photosensitivity, it leads to loss of accommodation. So we have to reverse the action of mydriatics. So what we do, we give myotics. They will cause meiosis, pupil will back to original size again. So this is the second use. Third use is, we prevent the adhesion of cornea and iris and the lens. To achieve this, we administer a myotic and a mydriatic alternatively. Look at this. We have cornea, we have iris, and we have lens. Sometimes these structures get adhered to each other. Either cornea adhered to iris or iris adhered to lens. We don't want this condition, it is not physiologically normal. So to treat this condition so that there will be no adherence, we will give a myotic and mydriatic alternatively. These are the uses of cholinergics as myotic. In next few minutes, you will get acclimatized with all these terms. What is post-operative paralytic ileus? What is myasthenia gravis? Cobra bite? How muscle relaxants are reversed? Everything. Let's start with myasthenia gravis. Every one of us know myasthenia gravis is a condition which is autoimmune, antibody formation will be there, NM receptors will be destroyed. Muscle weakness is there, muscle fatigue is there. Am I correct? We all know this? Now, what patients present with? Initially, the patient presents with ptosis, drooping of the eyelid, and we have studied that drooping of eyelid occurs because of levator palpebris superioris muscle. Second symptom is facial muscle weakness. Initial most symptoms are ptosis and facial muscle weakness. But in later stages, what happens? The limb muscles and the respiratory muscles, they also start weakening. And assume if a person is having weak respiratory muscles, it will be life-threatening after some time. So these are the later symptoms. You have to pay attention at these NM receptors. We have nicotinic and muscarinic receptors. In myasthenia gravis, nicotinic receptors which are present at the neuromuscular junctions, they are damaged. Let's have a look at this picture. This is our neuron. We have this synaptic vesicle in which acetylcholine is filled. When calcium influx occurs, when depolarization occurs, acetylcholine is released in the synaptic cleft. Normally, it should have to bind with this NM receptors present on the postsynaptic neuron and it will elicit its action. This is good. But what happens in myasthenia gravis? Our body makes antibodies against the neuromuscular receptors. These NM receptors get blocked with antibodies. These green color structures are antibodies. Because antibodies already get bound to the neuromuscular receptors, now acetylcholine won't bind. The action will not be elicited. Action is here, muscle contraction. Muscle contraction won't happen, muscle weakness will be there in the patient. So we discussed just now that there will be ptosis, drooping of eyelid and facial muscle weakness. So these are the initial most symptoms of myasthenia gravis and now you know why they are happening. Because the antibodies are blocking the NM receptors due to which acetylcholine is not getting bound. Before heading towards the treatment of myasthenia gravis with cholinergics, let's differentiate between these two, myasthenia gravis and cholinergic crisis. Do you know NM receptors are very decent ones. They don't accept understimulation, they don't accept overstimulation. In myasthenia gravis, we admit that myasthenia gravis causes understimulation of NM receptors. Agree? But there is another condition. If the NM receptors, the same receptor, if it gets overexcited, if there is cholinergic overactivity in the body, again the NM receptors won't work. Again there will be muscle weakness. So a person comes to you, you see ptosis, facial muscle weakness, and he is sharing you the symptoms of muscle weakness. So you will think first of all of myasthenia gravis, but this condition cholinergic crisis also possesses the same symptoms. And both of them have entirely opposite line of treatment. You can't confuse between these two. So myasthenia gravis is due to understimulation of NM receptors, and cholinergic crisis is due to overactivity of the cholinergic system, overstimulation of NM receptors. To differentiate between these two, we have two tests. The first is hydroponium test. What is hydroponium now? Hydroponium is a water-soluble acetylcholinesterase inhibitor. There are other acetylcholinesterase inhibitors also which are water-soluble, but why we are using hydroponium only? Because it is short-acting. It lasts for 10 to 15 minutes maximum. What we do, in the patient, we administer 2 mg hydroponium intravenously. We wait for 5 to 10 minutes. If the condition of the patient improves, we will assume that the patient was having NM understimulation. We gave a drug, cholinergic drug, because cholinergic system was not sufficiently active. Cholinergic drug make it active, patient is improved. It will be diagnosed as myasthenia gravis. But if there are already cholinergic crisis in the body, the cholinergic system is already active, you have given a cholinergic drug, now what will happen? The condition will worsen. So if the patient condition worsens, it will be diagnosed as cholinergic crisis. Got it? The second test is detection of anti-nicotinic receptors antibody in the blood. Very easy. We have seen these antibodies. If these antibodies are present in a person's blood, definitely it will be having myasthenia gravis. So this will be the second confirmatory test. Now treatment of myasthenia gravis with cholinergics. So cholinergics like neostigmine and pyridostigmine are used. These are water-soluble acetylcholinesterase inhibitor drugs. But these drugs are not given alone. These are given along with atropine. Now what is the use of giving 3 drugs? Let me clear it. Do you know cholinergic system has 2 kinds of receptors, nicotinic, muscarinic. We are facing problem with muscle weakness. It means we have to improve NM receptors somehow. We gave neostigmine and pyridostigmine. They block the acetylcholinesterase enzyme. Now acetylcholine is available for more time in the synaptic cleft. So acetylcholine will bind competitively to the receptor. Muscle weakness will be lost. But what about muscarinic receptors? They are also present in the same system. They are also present in the cholinergic system. And we know M1, M2, M3, M4, M5. If M1 is stimulated, there will be acidity. If M2 is stimulated, there will be bradycardia. If M3 gets stimulated, it will lead to many symptoms like increased salivation, increased sweating, diarrhea, vomiting, many more things. We don't want these side effects. So what we do, we simply want NM receptors to be active, but we want to block muscarinic receptors. So atropine is a muscarinic receptor blocker. You give atropine, all the muscarinic receptor will get blocked, only muscle weakness will be improved. That's why neostigmine and pyridostigmine are given with this atropine. Another line of treatment is a surgery called thymectomy, surgical removal of thymus. Now what is the relation of myasthenia gravis with thymus? You know in myasthenia gravis antibodies are being formed. The antigens responsible for producing these antibodies are present in the modified muscle cells which are found in thymus. So thymus is indirectly forming those antibodies in the body. If we remove thymus, those modified muscle cells will be removed. It means those antigens will be removed. It means antibodies won't be produced. Simple, antibodies won't be able to damage the NM receptors now. We use corticosteroids also. Corticosteroids, as we are very familiar, they are immunosuppressive agents. Myasthenia gravis is producing antibodies, immune system involved here. So we give corticosteroids. Another treatment is plasmapheresis, because blood has antibodies which are not beneficial for us. In plasmapheresis, we will simply remove those antibodies and re-enter the blood which is lesser in those antibodies. So it is also.
What is plasmapheresis?
Plasmapheresis is a procedure in which you take out blood from a person, remove a particular component out of the blood and re-enter the remaining blood into the person again. So here we are removing antibodies. Cobra bite. Myasthenia gravis is over. Now we see how cholinergics act in cobra bite. Cobra toxin is neurotoxic. It will damage the neuromuscular receptors again. Same as antibodies were damaging neuromuscular receptor, Cobra toxin possesses the same mechanism. It is damaging the NM receptor, it will lead to muscle weakness. Again we will give neostigmine. Neostigmine will enable acetylcholine to remain for longer time in the synaptic cleft. Because it is there for longer time, it can act on the remaining number of receptors which are available, which are not bound to those venom. And atropine, why atropine? Can anyone tell me?
Symptoms.
Muscarinic receptor blocker. Very easy. Third action, reversal of action of muscle relaxants. We give muscle relaxants mostly pre-operatively when we have to perform a surgery or procedure. But after surgery, we want patient to resume its normal life. So, to reverse the action of muscle relaxant, we give cholinergics. Atracurium and pipecuronium, these two are muscle relaxants. And to reverse their action, we give neostigmine with atropine. Again the same mechanism. Neostigmine will block the acetylcholine esterase enzyme. It will enable acetylcholine to remain in the synaptic cleft for longer time, and muscle weakness will be improved. Muscle will start contracting in this case. Post-operative paralytic ileus and post-operative urinary retention. After any abdominal or urinary bladder surgery, what happens? Intestine, urinary bladder, they lost their activity of movement. They lost their movements. Peristalsis don't happen in intestine. Urinary bladder detrusor don't contract. So, to overcome these two conditions, we give neostigmine. Neostigmine, it acts on M3 receptors. And we know M3 receptor is responsible for peristalsis, GIT motility, for detrusor muscle contraction, urinary outflow. But the contraindication here will be obstruction. If there is any kind of obstruction in the intestine or in urinary bladder, we won't recommend these drugs. We won't give neostigmine. It can lead to rupture or bursting of the intestine and urinary bladder. Now, belladonna poisoning or atropine poisoning. So, we know atropine is what? It's a muscarinic receptor blocker. M1 to M5, every receptor has been blocked. Now, there will be no action of these receptors. We have to reactivate or we have to make acetylcholine bound to this receptor anyhow. What we will do? We will give physostigmine. In the last 3-4 examples, we were talking about neostigmine. Now we shifted our discussion to physostigmine. Why? Because physostigmine is lipid soluble. M1 to M5 receptors, these are present in periphery as well as in central nervous system. If you administer neostigmine, it will only act in the periphery. It won't go to the CNS. But we have to improve symptoms in the CNS also. So physostigmine is given. It goes to CNS as well as it acts in the periphery. Physostigmine is an acetylcholine esterase inhibitor. It makes acetylcholine available in the synaptic cleft and competitively it frees the receptors. Alzheimer's disease. Dementia occurs in this disease. It is progressive dementia. It is neurodegenerative disorder. Occurs in old age commonly. What we give? We give rivastigmine, donepezil and galantamine. These 3 drugs are given in Alzheimer's disease. They make more acetylcholine available to the CNS so that the conditions, the symptoms of Alzheimer's disease are improved. Contraindications. If you have given attention up till now, contraindications are super easy. Contraindications means when you won't give cholinergic drugs. First is asthma or COPD, chronic obstructive pulmonary disorder. We know that cholinergic drugs cause bronchoconstriction. They cause the bronchus to constrict. If a person comes to you who is already having constriction in the bronchus, will you give a drug that will lead to bronchoconstriction? So it is contraindicated in asthma and COPD in this way. Second is bradycardia or heart block. Heart block also called atrioventricular block. There is a problem in conduction in heart block, and in bradycardia the heart rate is low. We know cholinergic drugs cause decreased heart rate. They cause decreased conduction of the cardiac impulse. If it is already present in the patient, why will you exaggerate it? So they are not given in bradycardia and heart block. Peptic ulcer disease. A person comes to you with increased gastric secretions, You give them cholinergics, neostigmine, pyridostigmine, etc. Now more acid is being produced. What will happen? The peptic ulcers will get worsened. So peptic ulcer disease is also a contraindication for cholinergic disease, cholinergic drugs. Hyperthyroidism. It is seen that patients having hyperthyroidism, in such patients, if you give cholinergic drugs, what happens? There will be cardiac arrhythmias and other cardiac complications like atrial fibrillation. So these drugs are contraindicated in hyperthyroidism. Now, epilepsy. We know in epilepsy there are frequent attacks of epilepsy. When cholinergics are given in patients with epilepsy, what happens? The threshold, the seizure threshold for epilepsy is decreased, leading to more frequent attacks of epilepsy. Urinary obstruction, we have just seen. In urinary obstruction, if a cholinergic drug is given, it will cause increased contractility of the urinary bladder, and because there is obstruction, urinary bladder can rupture. So they are contraindicated. Similarly, in GIT obstruction, we won't give cholinergics. It can also lead to rupture. Parkinson's disease. Cholinergic drugs on long run, on chronic use of cholinergic drugs, what happens? They decrease the activity of dopamine in the CNS. And we know decreased dopamine activity means it will lead to Parkinsonism. So it can hamper Parkinsonism, it can exaggerate. Decent MI. If a person was having heart attack and you gave them cholinergic, we know in heart attack the efficiency of heart is compromised, heart rate is lower than normal, BP is lower than normal. But in cholinergic drug administration, what will happen? It gets further lowered, BP and heart rate. So it is also contraindicated. Whatever I told, this was reference from K.D. Tripathi. Thank you so much for your attention.
पहली स्लाइड से ले लो। हाँ, next.